Listen up, men. I know it's not something you like to talk about, but not talking about it is dangerous, and that is your health. Especially talking about things like your colon, your prostate. Not talking about it costs lives, so we have some very, very wonderful experts today who are willing to talk about it, discuss it with you, let you know the signs and symptoms. Welcome. We're talking about colons and prostates. We have Dr. Thomas Shehab, a gastroenterologist, and we also have Dr. Eduardo Kleer, a urologist and also a robotic surgeon. What is it about men that they don't want to talk about their health and they don't want to talk about colons or prostates because it's so uncomfortable? How do you make them comfortable?
I think the main thing, Lila, is once the subject's breached, people are comfortable. It's the idea of bringing it up. And I think that if you can take the message to people that there's a lot of people who go and work out to keep their heart healthy, but yet they'll ignore things that we can take just as good a care of if we bring up the subject. And so if you can just bring the subject up with them, people will feel a lot more comfortable talking about it. There's a lot of societal stigma about talking about these things. What
happens when people come in?
Often their wife will make the appointment for the patient, but now in the news and in the media, where you start hearing more about conditions such as erectile dysfunction and commercials for medications like Viagra and so forth, and also they're advertising a lot of prostate medications. I think it's facilitated the opportunity for men to come in with a more open mind and bringing those subjects up much more at ease.
Well, the St. Joseph Mercy Health System is taking a big step October 5th in Canton to make a real event out of this, a men's health event. Tell me a little bit about it in Canton on October 5th.
We're going to be doing prostate screening, and we're also going to be giving some lectures about prostate, PSA, getting checked for prostate cancer. And also we're going to be showing the Da Vinci robot, which we'll talk about later, which is a robot that we use often to operate on men for prostate cancer. So it should be an exciting event.
People will actually see that robot.
They'll be able to not only see it, but also play around with it as well.
Now, for people listening who don't have insurance, and so the reason they go to the doctor isn't just that they don't want to talk about it, they can't afford it. Why is this men's health event on October 5th in Canton so important?
Well, especially for men that don't have insurance, they're often not getting the type of checkup and advice that they need. So we're going to be able to talk to them about their prostate and check to make sure that they don't have some type of a prostate condition or prostate cancer that has not been found out yet.
All right, so let's talk about the prostate and feel real open and comfortable talking about it. What can men do to protect their prostate and keep it healthy?
Well, Lila, the prostate, like any other organ, is good to, it responds well to good nutrition, so it's good to eat a healthy, varied diet. As far as specific foods that may help the prostate, a low-fat diet is good for the prostate. They have found, for example, that men who live in the Orient, like Japan and China, over there they have a low incidence of prostate cancer, but once they come and live in the United States, their incidence of prostate cancer goes up just like the rest of the American population, and I don't know, that may be the same as well for colon cancer as well. But a lot of it has to do because of the increased fat in the diet here in the United States.
And people talk so much about the importance of eating lycopene. So what do they mean by that?
Yes, lycopene is contained in tomatoes, so that's actually very good for the prostate. So anything with tomatoes like ketchup, tomato paste, tomato sauce, tomato juice, tomatoes happens to be a good nutrition for the prostate. Other foods that are good for the prostate are soy, either soy milk or tofu is good. Green tea and black tea also appears to have some benefits as well. And basically, just a regular multivitamin may be useful as well.
And usually we think of fresh fruit as being the most beneficial, but in this case, for the lycopene, they say the tomato that comes out of the can might even be better.
Yeah, I'm not exactly sure the science behind it, but definitely science has shown that tomato and lycopene is very good for the prostate.
All right, now this is the part I really want to understand. What's the difference between an enlarged prostate and prostate cancer? And if you have an enlarged prostate, does that mean you're more susceptible then for cancer?
Sure, Lila. First, many people talk about the prostate, but they don't really know where the prostate is in the body. At least I remember I never really learned that much about it through high school and even college. But the prostate is a small organ, it's about the size of a walnut that surrounds the neck of the prostate. And as men get older, it's natural for the prostate to enlarge. Typically, the prostate will enlarge in the inside part of it so that it starts to impinge upon the neck of the bladder, making it more difficult for men to urinate as they get older. So that's why as men get older, they typically will complain that the flow of stream is not as good, that they have to urinate more frequently than they had to. They have to urinate more urgently. They have to get up at night. And that's because of that natural aging process of the enlarging of the prostate on the inside. Now, the prostate enlarges in about 80% of men. Prostate cancer, on the other hand, grows on the outside part of the prostate rather than on the inside, and prostate cancer affects approximately 1 in 6 men. So typically, prostate cancer will not cause urinary difficulties unless it's very far advanced along. So that's why most men, when I see them in the office and they're complaining that they're having urinary difficulties, they're concerned that they could have prostate cancer. But in fact, nowadays, it's very rare that that's what's causing the urinary problem. Now, to check for prostate cancer, we typically will do a finger evaluation and a PSA. That's how we catch it early. Typically, prostate cancer early on does not cause any symptoms.
Dr. Kleer, you have a very appropriate name because that was a very clear description. We want to remind you that we want you involved in this discussion. You can call in. The number to call, 248-356-0077. That's 248-356-0077. If you're afraid or uncomfortable going into the doctor's office, you shouldn't be afraid to talk to us now anonymously on the phone. Let's go to Bloomfield Hills. On the line, we have Becky. Becky, are you there? You there, Becky? Hi, Becky. What's your question? Ooh.
I'm sorry, I didn't hear the question.
So there's blood in his urine, especially after he works out every few days. How concerned should they be?
How old is your husband? 37? 47. So certainly blood in the urine is abnormal. Most of the time in men that age, especially with a history of blood in the urine after working out, often may suggest the presence of a kidney stone that kind of rattles around when he's moving around, when he's doing a lot of strenuous activity. However, he needs to be fully evaluated to make sure that there isn't an occult polyp perhaps in his urinary tract. So he should definitely see a urologist, and they were going to do testing which would include an x-ray of his urinary tract and perhaps even a scoping of his bladder to make sure there's nothing else serious going on.
Becky, is he going to be comfortable going to the doctor?
Not usually. He keeps saying it's no big deal. It's just because he's working out and he strained himself.
Yeah, I mean, but he definitely should be evaluated. Probably nothing serious at that age, but he definitely should be evaluated by a urologist for that condition.
He's got a good wife. Thank you, Becky.
Thank you.
Thanks for calling. So the thing that I heard about yesterday, which sounds so exciting, is this new experimental test that may actually spot prostate cancer sooner. This is a whole new thing. It just came out yesterday, and what's interesting about it is it may be more accurate than the PSA test, which actually is the industry standard for detecting prostate cancer. But there's some problems with the PSA test. Can you talk about the PSA test?
Sure. And by the way, thank you for giving me the medical information that I need.
Yeah, I'll get more on that for you. Stay tuned.
But anyways, yeah, PSA stands for prostate-specific antigen, and what it is, it's a protein that's normally made in the prostate, and normally it's secreted into the bloodstream at very low levels. However, any condition in the prostate will cause that PSA to be secreted at even higher levels into the bloodstream, and that's how we can pick it up. So PSA, or prostate-specific antigen, is a test that's very specific for the prostate, but it's not particularly sensitive for prostate cancer because so many conditions in the prostate cause its levels to rise. So for example, having an enlarged prostate will cause the PSA to go up. Having an infection in the urine or in the prostate will cause the PSA level to go up. Having urinary retention where one can't urinate, that will also cause the PSA to go up, and as well as prostate cancer. So
you can end up with a lot of false positives.
Exactly. So when a patient comes in with an elevated PSA blood test, it's my job as a urologist to try and figure out why that PSA is elevated.
So what would you tell people? At what age should a man be getting a PSA test?
Right, that's a very good question. Typically, most men who do not have a family history of prostate cancer should start getting their PSAs checked in their early 50s. However, men who have a family history of prostate cancer, or African American men, these are both groups of men that will have a higher probability of having prostate cancer and also a higher probability of having a more aggressive type of prostate cancer. Those men should start getting a PSA checked in their 40s. Now, one point I want to make is a lot of men think all I need is that PSA and I'm done. The PSA is also not a substitute for the digital rectal examination or the prostate test, which causes a lot of embarrassment.
A lot of discomfort.
Discomfort. But one does not substitute for the other because we know that 20% of prostate cancers do not cause the PSA to rise. So the two tests complement each other. Just getting a PSA by itself does not do the job. You need both tests done.
Now, it's not something you wake up and say, gee, I wish I could get a digital rectal exam today. How do you make a guy comfortable enough, especially if they have any kind of, bleeding or anything that really needs to be tested? How do you make them comfortable enough?
Well, first I tell him my fingers are not as big, certainly not as large as Dr. Shehab. I was not a football player in college.
Yeah, those are big fingers for a gastroenterologist.
But anyways, I tell them, women have to have a public examination and you have to pay your dues too, and we're just trying to, it's a minor inconvenience for potentially a lot of benefit.
Let's move from the prostate to the colon. One thing about prostate cancer, but also colon cancer, these are things that are more than 90% curable if detected early, very treatable, but you have to be willing, A, to talk to the doctor and then go in for that exam. So, Dr. Shehab, first of all, at what age should someone get that colonoscopy?
Well, Lila, clearly at the age of 50. At the age of 50, people should start regular screening for colon cancer. There's a variety of different tests that people can use. Colonoscopy is the one that's most often done. 50s for people with no symptoms and no family history. Folks who have a family history or have symptoms need to consult their doctor to decide if they need to have the test earlier than the age of 50.
What about the sigmoidoscopy?
Sigmoidoscopy is a fine test as if it's compared with not having a test at all. Sigmoidoscopy looks at the bottom third of the colon.
So you're only going halfway. Some people have compared it to getting a mammogram on one breast because you're not seeing the entire colon.
That's the perfect way of thinking about it. It is, most people who were going to have mammography wouldn't want to have it just on one side. There was a sense for many years that a sigmoidoscopy would pick up most of the colon polyps and colon cancers. Over the last decade and a half, it's been very clear that they're not just in the lower part of the colon, they're through the entire colon. And so if you're going to get the test, you're really going to look for the opportunity to have the best outcome, then looking at the entire colon is the way to do it.
People don't like to say colon, stool, blood in my stool. People don't want to talk about that stuff. I know my own brother had blood in his stool for weeks, maybe even months before he finally talked about it. And I said, dude, get to the doctor. That's one of the #1 signs and symptoms of colon cancer. So how, if there are women perhaps watching right now who want to convince their husbands that it's time to get the test, what do you say?
Well, I think it's relatively easy if you think of it this way. In the world that Dr. Kleer and I live in, you see people who wish after the fact that they had the test. And so I tell my men all the time, you're working hard, hopefully to get to your retirement, many people, and wanting to have the time. How sad would it be if you now hit that time and what you could have taken care of, your cholesterol, your prostate, your colon, now comes back to give you a serious disease that takes away years from your life that could have been absolutely prevented. So to be quite honest, it's always the thing you don't know that hurts you. If you can have these tests, it's better to put up with the digital rectal exam, the colonoscopy, than it potentially limit the number of years you have to spend with your friends and family.
If you're wondering, well, am I at risk for colon cancer? Let me put it to you this way. If you have a colon, you're at risk for colon cancer. There are people, though, who are more at risk than others. I want you to join the conversation, too, if you have questions. 248-356-0077. We're going to go through some of the signs and symptoms. If you think that, this could be me, you have experts here from the St. Joseph Mercy Health System that can help you with those questions. 248-356-0077. What are the symptoms?
Well, the vast majority of people with colon cancer don't have symptoms, and that's one of the key things why we talk about screening. Screening means finding people who don't have symptoms of the disease. Clearly, symptoms that we think about in people who are younger would be symptoms such as blood in the stool, change in the shape of the stool, significant change in bowel habits. Those are the main symptoms. But the key issue is that most people who have colon cancer don't have symptoms until it's far advanced. Hence the reason for not putting it off just until I get symptoms. That's when we really lose the battle.
Now, this is what I heard about the timeline. Tell me if it's correct. It takes about 5 years to grow a polyp in your colon, about 5 more years for that polyp to grow into cancer, and then about 5 more years to kill you. It's like a 15-year cycle. But if you catch it really early in that 15 years, you have a much better chance, right?
Absolutely. And you know, Lila, you hit that right on the head. It is a slow-growing disease until it's no longer slow-growing. Once it becomes cancerous, it can grow quite quickly. And so the real concern is that you can't bet which of those 5 years you're in as a patient, and hence the reason why we push screening so quickly. Polyps do grow from normal tissue to small polyps, which are like growths or mushrooms in the colon that then can grow onto colon cancer. Not all polyps become colon cancer. The problem is you can't gamble on which ones will not progress and which ones will progress.
So if I'm worried about a brother, husband, father having prostate cancer, what are the symptoms I should be asking them if they're noticing?
Well, the good news is that nowadays it's not as common as it used to be, say, 20, 30 years ago, that men present with advanced prostate cancer. So early on, it's not common now that we find men with advanced prostate cancer, but if they do have advanced prostate cancer, they may complain of having a lot of back pain or bony pain, because prostate cancer can advance into the bones. And they may have urinary difficulties if the prostate cancer is quite large, or blood in the urine, and just overall just a general deterioration in their health.
And what's the process like? If somebody comes in and says they have one of these signs or symptoms, what's the process like going through the testing?
Well, so in order to diagnose prostate cancer, what we do is we do first an ultrasound of the prostate. It's a transrectal ultrasound of the prostate, which allows us to visualize the prostate.
Okay, what's that all about? Tell me what that process is like.
I don't think it's as bad as a colonoscopy, but basically we use an ultrasound probe that we insert transrectally. It's done in the doctor's office, and then that gives us an excellent visualization.
Any pain at all?
You know, there's some minimized discomfort with that procedure in itself, but after the probe is in, generally it's very well tolerated. Mm-hmm. And then we can visualize the prostate, and then sometimes, even if the ultrasound of the prostate is normal, we will still do often biopsies of the prostate because, for instance, if the PSA is unusually high or if the PSA has been rising over a certain period of time. And what we do when we biopsy the prostate is we numb up the prostate using a needle, where we numb up the nerves on the sides of the prostate, and then we insert a very small needle that goes through the probe right into the prostate. It goes through the rectum and takes small pieces of the prostate. And there's a risk for infection with that procedure, so we always give patients plenty of antibiotics to minimize that risk.
And what if cancer is detected?
Well, if prostate cancer is detected, there's really a number of treatments available, and we base our decisions on the type of treatment they're going to offer based on a number of factors. One is the overall age and health of the patient, also how aggressive the prostate cancer is. Certainly someone who's perhaps more frail or has other medical conditions like perhaps heart failure or lung failure, or they've had strokes, we're not going to recommend a very aggressive treatment for that patient because it may not impact on their life expectancy.
Is it true that most men will develop some form of prostate cancer as they get past 80 and 90?
Yes, autopsy studies have shown that by the time men reach 80 years of age, approximately 40% of all men will have prostate cancer detected.
So that elevated PSA is pretty much a normal thing once you get into your 80s.
As we get older, the PSA does get higher, and that's one reason is because it's normal for the prostate to enlarge as we get older. So an enlarged prostate causes the PSA levels to go up, so it's quite common for the PSA to get older as we get older. Now, we talked about, so someone who has other medical problems, we're not going to be as aggressive in treating the prostate cancer. On the other hand, someone who's younger and healthier and who has a more aggressive prostate cancer, has many years left to live, we're going to recommend a more aggressive type of treatment, which may involve, for example, surgical removal of the prostate called radical prostatectomy, or perhaps radiation treatments to the prostate. Sometimes we use hormonal therapy as well for prostate cancer. Just depends on that specific situation.
What other therapies? Like I remember hearing about the seeds and the freezing and
Right.
all of that. Tell me about that.
Right. So non-surgical options for treating prostate cancer would include radiation, and there's various ways of giving radiation. The most common way of giving radiation is called external beam radiation therapy, where you go to the radiation doctor for 7 or 8 weeks, about a half hour each time, and a half hour a day, and you receive external radiation into the pelvis. You can also place radioactive seeds into the prostate using ultrasound of the prostate to guide the placement of the seeds, and that's done with an anesthetic. And that's just a one-time deal. You can also do a combination of seeds and external beam radiation. And there's also another type of radiation treatment which is available at St. Joe's Hospital. It's one of the few medical centers in the state and in the country. It's called CyberKnife, which has reduced the length of time for the external radiation from 7 to 8 weeks to only 1 week.
Talk a little bit about CyberKnife and how miraculous that is.
Yeah, well, CyberKnife has traditionally been used for treating patients with brain cancer. And now, because of the success with that, they're looking at it in treating other types of cancers, such as, for example, prostate cancer or pancreatic cancer or other types of cancer, especially in some conditions where surgical option would not be a good idea. So CyberKnife gives patients one more type of hope in treating their cancer.
All right, let's get back to the bottom line, the colon. So somebody comes in, you find that polyp in their colonoscopy. What's the next step when we find out that, yes, it is in fact cancerous?
So let me take a step back on the process for the colonoscopy, because some people may not know. So for folks who do have a colonoscopy, the most common complaint is the night before. They take a medicine to clean out their colon.
That is, having had a colonoscopy, the night before is much worse than the actual
Absolutely,
procedure.
and almost everybody says that. But when they have the colonoscopy, we look through the entire colon. We actually are watching a camera that's on the end of the scope, and we pass it through the entire colon.
Just in case you don't understand why the night before is more miserable. That you either take a pill or drink the stuff.
Absolutely.
And literally everything inside you is emptied out.
Absolutely.
Basically, you take a book to the restroom
And you tie up
stay
the-
there for a while.
That's correct.
Okay,
That's
go
correct.
ahead, continue.
However, the gain of it is worth the price you pay for that evening that you spent.
Right.
We sedate you for the procedure, so most patients, after they check in, they're given an IV, they're given a sedation, they go to sleep, we do the procedure. Now, in about 30 to 40% of people, we find a polyp. Polyp is a small growth. In a small percentage of the polyps, we actually find a cancer. So to answer your question, if we do find a cancer, a polyp, or either a polyp that looks cancerous or a cancer itself, then that's at the time when the gastroenterologist will transfer the patient's care to a surgeon. Surgery is the main treatment for colon cancer. Now, there are times where the cancer is just in the polyp when we remove it at the time of the colonoscopy, because most polyps we remove without ever having the patient have to have surgery. The management of colon cancer has changed drastically. Most of our patients we see are older. Imagine I have colon cancer, I have to have an enormous operation, I have to end up with a colostomy, a bag for the stool. It's going to alter my life forever. That's not the case nowadays when we manage that disease.
So when you talk about preservation, because people want to preserve the colon, it's the same concern, probably even more for some men when it comes to the prostate. They want to make sure that after this whole procedure is over, they can still perform. Talk a little bit about that.
Sure.
Because that would keep a guy from even wanting to talk to you about it in the first place.
Oh, absolutely, and that's a very good point, Lila. We find that all the time. So, first, surgical removal of the prostate or radical prostatectomy has some possible life-changing side effects. And the principal ones are, one is that there is a risk of urinary incontinence or urinary leakage. And nowadays, with our surgical techniques, generally that tends to be somewhere between 5 and 10%. However, it can take up to a full year for men after a radical prostatectomy to fully regain their urinary control.
So they shouldn't panic at the beginning. You warn them that, look, it's probably not going to work for a while.
Absolutely. I try to reassure them that it's normal to have some degree of leakage, especially during that first year. 90 to 95% of the time it comes back. And also, if it never comes back, we do have various ways that we can try and fix that for them so it does not continue to be a permanent problem. Well, there's two ways that one can do that. One is called a sling operation, which is a very similar operation to what women get when they have complaint of what's called stress urinary incontinence. So it's a sling for men. And if that doesn't work out, or for men who have severe incontinence, there's something called an artificial urinary sphincter, which is a wonderful device for men. It's a sphincter that we place around the urethra that's with a little pump that goes in their scrotum that they can pump in order to urinate. That also works extremely well. It's all, by the way, it's all underneath their skin, so no one can tell that they have it.
Right.
And
it's uncomfortable to talk about, though. I mean, I don't even have a prostate. I'm uncomfortable.
well, yeah, of course, and those are not subjects that we talk about every day, just like the colon. But like Dr. Shehab said, it's something that you don't want to say 10 years down the road, gosh, I wish I would have done something about it, because now it's too late. So, and then the other potential risk of prostate cancer surgery is the risk of erectile dysfunction. Nowadays we have very advanced surgical techniques where if someone has very good erections before the operation, there's often close to 75% of the time we can still save their erections after the operation, because now we know where those nerves are that result in erections, and we can often spare the nerves while we remove the prostate. But not every man is a candidate for that, because sometimes if there's cancer in the vicinity of those nerves, then it may not be a good idea to save those nerves, because you may be saving cancer at the same time.
We're asking and answering all the questions you may be too shy to ask yourself. We have experts from St. Joseph Mercy Health System, Dr. Kleer, our urologist and robotic surgeon, Dr. Shehab, a gastroenterologist from St. Joseph Mercy Health System. And we're saying all kinds of things that people aren't usually comfortable talking about, prostates and colons. I heard you say scrotum. We're just saying it openly and giving you an opportunity to ask questions as well. There are some people who don't want to call in, although the number is 248-356-0077, but they are emailing. So let's get to Bob, whose question is, are there any dietary foods that prevent colon cancer?
Lila, there's a lot of things that have been thought about to prevent colon cancer. We know for colon health, fiber is a key. So the more dietary fiber folks get...
When you say fiber, specifically what are we talking about?
So we're talking about fruits, vegetables, and for folks who don't have a lot of fruits and vegetables, although we should just for our general health, things like Metamucil, Citracel, fiber supplements.
Is it okay for me to take one of these supplements?
Absolutely. Those supplements have really no downside and a significant potential upside. The other things that in terms of diet are all the things we hear about already for heart, for prostate, and otherwise. It's less of the red meat than we typically eat, more fruits and vegetables, more antioxidants are all beneficial for the colon.
What about red wine?
Red wine has been talked about for a lot of potential benefits, and the answer in the colon probably doesn't make a big difference. But key, no matter what we do diet-wise for colon, nothing comes close to having colon cancer screening compared to the diet based on the studies we know. And
you have an opportunity, obviously, to learn more about this personally and meet the docs. It's at the Men's Health event Tuesday, October 5th. It's this Tuesday, 6 to 8 p.m. at the St. Joseph Mercy Canton Health Center. And they'll have all kinds of interesting people there, including Freddie Scott, a prostate cancer survivor, former NFL wide receiver and college football Hall of Famer. You're also a college football player. I mean, you know that sort of culture of men who don't really want to talk about their health.
Absolutely. Freddie Scott was a good football player. There's a reason I'm a doctor now, not anything else. So it's not of the same category. But
do you know Freddie's story?
I do only peripherally, not personally. But it's not an uncommon story. It's not an uncommon story to have somebody who has great success in their life, whatever that may be, as a parent, as a teacher, as a reporter, as a football player, and then as they age, something that potentially could have been caught earlier doesn't get caught as early. And he's going to speak to the fact of screening being very important, which I think is the key message for both of us today. I'll give you an example. One of the things we do is we cut down and break down barriers. There is a myth, urban legend, that, since we talked about erectile function, that there were a group of men who weren't having colonoscopy because there was this legend among men that if I have a colonoscopy or a digital rectal exam, I will lose my ability to function sexually.
Not true.
Absolutely not true. However, what's taken a long time is we see the patients who come in. It takes community events and otherwise for us to see the patients who don't come in to find what the biases are that keep them from coming to see us. And so I think it's been very telling that sometimes it's nice to flat out address those issues, which is after your colonoscopy, after your prostate screening, you're the same as you were before, except you know a lot more about your health than you did prior to the screening.
I think to get a lot of men to a men's health event, oftentimes it's their wives driving them there. Are women invited, or what happens?
Absolutely. Women are welcome to come.
All right, great. Can I put you guys on the spot, and will you answer me honestly?
Yeah.
Have you had a colonoscopy?
I have.
You did?
I have not. but I'm not 50 yet. So
Okay, but you will.
I will.
All right. And do you tell the people in your family as they reach 50 to get these exams?
Absolutely. In fact, they don't go a day past 50 without getting the colonoscopy, or else I drive them wherever they need to get. And I think that's part of the reason. I had a family history, so I had mine early and continue to have them. And the answer is that all they have to do, and I tell patients this all the time, come and spend a day with me telling someone who could have had a colonoscopy at 50 that they now have colon cancer, and you will go get your colonoscopy. Virtually everyone will then get their prostate cancer screening. It's just until it hits close to home, or it hits someone in the media, or it hits somebody on the news, people like to ignore. We're great at denial. And so the answer is yes, absolutely. My family have had both screening tests as often as they need to have them.
I have another thought in my mind. You know those automatic flushers? I think they're a bad thing because it's important, and I know this is super uncomfortable to talk about, especially during the lunch hour. But it's important to look and see what's coming out of you.
I don't think that's an unreasonable statement. I think that the answer is, though, that is reasonable to do. It can tell you a fair amount of information. But even if you do, and everything's normal, and you're the age of 50, the fact that things look fine in the commode doesn't mean that you don't get the screening test, because too often we miss folks who don't have symptoms.
But if you have blood in the stool?
Absolutely. That is something, blood in the stool, blood in the urine, you need to see your primary care physician and have that evaluated, period, no matter what you think. I thought it was very telling. The patient's husband earlier said, well, I work out, I must jiggle something. No. That's one of those myths we like to think that doesn't fit in our world. And so the answer is you need to see somebody and have it evaluated.
All right, we have an email from Mike. I'm a black man with a history of colon cancer in my family. What age should I get a colonoscopy? So if you don't have history, the age is 50. If there is a history, what's the age?
Well, it depends on when the patient's family member had cancer. For most people, it's starting at the age of 40, so 10 years earlier. And I congratulate Mike. You know, one of the things we found, unfortunately, colon cancer in African American folks tends to be found later. It tends to be more advanced when it's found, and there's some bias in a number of different communities where folks get screened less often. So I congratulate Mike for bringing up that the answer is, typically speaking, with a family history of colon cancer, screening should start at the age of 40. But the key issue is to consult with your doctor, and your doctor will help you to make that decision. If
you're just tuning in, we're talking to two experts from the St. Joseph Mercy Health System, a gastroenterologist and a urologist, about prostates and colons, a thing that men don't want to really talk about. And we're really trying to emphasize that this Tuesday night, October 5th, at the St. Joseph Mercy Canton Health Center is a men's health event catered to men who perhaps are way overdue for an exam on their prostate or way overdue to even talk about their colon. This is your opportunity to not only meet interesting people, meet interesting doctors, but get the information that really could save your life. If you want to get in on the conversation, it's 248-356-0077, or drop us an email and we'll try to answer your question. I know that it's tough to talk about colons. It's even tougher to go into a doctor who perhaps you didn't know before and have them do a colonoscopy. You think it's tough for you? I had my colonoscopy, because I did have a family history, on television, prime time. Can you imagine what that's like? So it is, but you know, I survived. What really struck me is how simple the actual test was. You can be sedated for the colonoscopy. I asked them not to, but because I'm smaller, as soon as they gave it to me, I was out. And by the time I woke up, he said, it's over. I have a clean colon. Hasta la vista. It was done. And besides a little air in my tummy, that was it.
That's the typical experience. Most people have. In fact, there are great studies. 98% of people who have a colonoscopy, when it's over, will say, boy, that was a lot better than I imagined. Our worst enemy is what our fears are. Right. We imagine what's going to go on, or we hear that my cousin's uncle's friend 3 Tuesdays ago had a colonoscopy. It was a bad experience. The reason is it's a little bit like buying, in the old days when a car was a lemon. No one comes up to you and say, I have this car, it's the best car ever. The person who has the bad experience tells 25 other people. It doesn't represent what you experienced.
Right, it was great.
And I can tell you,
I don't want to say great. It wasn't like great, but it was great. It was fine.
Well, you know, one of the best things we've had is folks in media have been terrific. You know, there was actually a paper published after Katie Couric had her original colonoscopy on TV. Colon cancer screening rates went up 25% in the subsequent year. That saves people's lives. People should be incredibly grateful for those type of opportunities. They show that you can vouch for the fact that here's what my experience was, here's what we expect your experience to be, and that's what we hold ourselves to, is to try to provide you with that type of experience.
So what's the key message to people who are listening, saying, all right, I'm willing to tell everybody I know? What should they be telling people?
Well, people normally go to their doctors and they get checked for their blood pressure, their blood sugar, their cholesterol, and just with a few little extra steps, as far as the prostate is concerned, they can also get the blood test checked for prostate cancer, the PSA, and the digital rectal examination as well. At really no pain at all to the patient, and it's kind of no pain, no gain, basically, but very, very little pain to the patient.
Most men would rather get dirty looking under the hood of their car.
Exactly.
And know more about their cars
Right.
than they do about their own PSA level. They
Right.
probably know the oil level in their car better than they do their PSA level.
Exactly.
What's the danger of going to 55 or 60 without ever having a PSA test?
You know, now that you bring it up, there's actually the PSA blood test, unlike colonoscopic screening for colon cancer, is somewhat controversial because there is some literature out there that says that PSA screening may not be that beneficial in detecting the type of prostate cancer that will actually limit someone's life. So there is some people I see in the office who, in their 60s or 70s who've never had a PSA, and they're fine. But on the other hand, you have some patients that, where the PSA blood test comes up quite high, or their digital rectal examination comes back abnormal, who wish that they would have had it done. So, but generally, as a urologist, I've seen numerous cases where many men's lives were saved due to the PSA being checked, especially at an earlier age. So certainly it may not help everybody, not everybody in the population, but from what I've seen, certainly the potential benefits appear to outweigh the risks.
Now, one thing that so many people go for is the virtual colonoscopy. So they'll lay in a machine, it'll tell them virtually what's in there, and they'll spend the money for that, which often is not paid for by insurance. But there's a drawback to getting a virtual colonoscopy, isn't there?
Well, there's the potential drawback. From our point of view, as advocates for screening, whatever test you get is better than no test.
That's right.
And so whatever test people get, whether that be a test for blood in the stool, or a sigmoidoscopy, colonoscopy, or virtual colonoscopy, it's better than no test at all. The virtual colonoscopy was touted originally as going to be the magic bullet. You lie down on a table, a CT scan does pictures, and we find the answer. What we found is about 40% of the people who had virtual colonoscopy need to have a colonoscopy to look at what was found in the virtual colonoscopy.
So you end up spending the money for the virtual colonoscopy and getting the colonoscopy anyway.
That's correct. Now, some folks who are big advocates would say, if I have the virtual colonoscopy and it's completely normal, I save myself from the colonoscopy. However, for virtual colonoscopy, people still take the prep the night before or the day of, so you go through really what's the worst part of the procedure. But again, I think that when you look at the American Cancer Society recommendations, there are a number of different screening tests. Any screening test is better than ignoring this. It's what you don't know that hurts you.
Is there any way to make that night before a little more bearable?
There are ways, and I think that we have evolved dramatically. When we first started doing colonoscopies, people would take 4 liters of fluid the night before. People take about a third of that volume, a third to a half. It's mixed usually in something like Gatorade or another product that has the flavor of the product you're drinking as opposed to being salty or tasting bad. And so the answer is the palatability of what you drink, the taste, is not as bad as it used to be. The volume is not as bad as it used to be. But there's no way to really eliminate the period of time that you're going to spend around or in the bathroom the evening prior to the procedure for us in order to be able to see what we need to see.
I know one of the tough things when you're dealing with as many patients as you deal with at St. Joseph Mercy, keeping up with the latest breaking news. And I'd love for somebody to print out this latest prostate cancer screening test that could be a real potential breakthrough so I can get your reaction to it. But what do you think is the greatest innovation that we've seen in the last year or 5 years, first in prostate and then in colon cancer?
Well, as far as the latest innovation, as far as the treatment of prostate cancer, I think it has to be what's called a Da Vinci robot. And basically, by the way, it's called Da Vinci because Leonardo da Vinci was the first one to think about the concept of a robot, and that's why it's called Da Vinci. But basically what the robotic system is, it's a device that allows a surgeon to do a complicated operation through small half-inch to 1-inch incisions. It's basically an advanced form of laparoscopy, and many patients have had laparoscopic surgery if they've had, for example, their gallbladders removed or their appendices removed. And what it is, it's you have to first distend the abdomen with air to give room to insert these instruments. And then we place a special camera in the patient that allows the surgeon to see everything in 3 dimensions. And furthermore, everything's magnified 10 times. So the optics are fantastic and actually can see much better than how you would see in an operation where you're not doing it with the robot.
And just the dexterity, because as a surgeon, when you put your hand on someone, you can't move it in the amount of directions that a Da Vinci robot can move, correct?
Right, and so traditional laparoscopy, we describe the instruments, the surgeons talk about they're kind of like hockey sticks, where you can only move it side to side, up and down. And I brought for you and the audience an example of what a Da Vinci instrument looks like. And you can see here's a penny, and here's the end of the instrument that we place in the patient.
Wow.
Very, very tiny. And the key here is that it's operated through cables that run from these pulleys. And these pulleys allow the robot to duplicate whatever movement the surgeon does in any way, shape, or form. So if I move my wrist side to side, up and down, I want to grab something, these instruments allow us to do that. And because these instruments are so small, it allows us to get down way deep in the pelvis, for example, where the prostate is, where before we couldn't get our hand in. So here's my hand, and here's the end of that instrument.
Wow.
And you can see the potential benefit that this would allow the surgeon.
Are there Da Vinci benefits in gastroenterology?
There are, absolutely. And in fact, it's revolutionized really colon cancer surgery. So now take the patient you mentioned earlier, who we do a colonoscopy and we find a colon cancer. Previously, they would have a large incision along their abdominal wall. They would have a major recovery. Now we have surgeons who will do the colon cancer surgery with the Da Vinci. It allows them to remove the involved portion of the colon, reconnect the colon at that surgery, so there's no colostomies or anything that people fear very greatly, and it accelerates their recovery while giving them an equally effective surgery. So absolutely, in fact, the use of the Da Vinci in colon cancer surgery is something that our surgeons, specifically Dr. Kleer at St. Joe's, have absolutely revolutionized and brought to be a very common thing. So there are patients who will say, I won't have a colonoscopy because I don't want to know what's there, and then I don't want them to have to deal with it. This really, again, we're taking away the barriers that keep people away and making it as user-friendly as possible.
When I choose my gastroenterologist for my colonoscopy, don't I want the one who does the most colonoscopies possible, or how do I make that choice?
It's a great question. I think that to a point, absolutely. Can several people do a colonoscopy, push the scope through the colon? Yes. But clearly,
I got uncomfortable when you said that.
In the world of gastroenterology, we're trained to a point to be remarkably effective. For instance, we do upwards of about 19,000 colonoscopies a year. Wow. That's among about 17 providers. So we have a very high volume. And just like anything in life, somebody who is going to make you a desk as a woodworker, someone who's going to fix your car, having expertise and high numbers of experiences allows you to be more effective. And the literature would suggest that doctors who do more of these procedures have better rates of finding polyps, better rates at being able to help you get what you came to have the test. Because the test is not perfect. There is clearly the potential for operator error or not. And so you want to have somebody who not only can do the technical part, but understands what they're seeing and how to deal with it once they find it.
And what about choosing a man or a woman? Do you find that most men are more comfortable with a male doctor, most women are more comfortable with a woman? How does it work? You know,
it's very surprising. There are a population of folks who are very, very strong in their opinion of a man wanting a man or a man wanting a female doctor or vice versa. Clearly, the literature has shown in the past that some women avoided colonoscopies because for a long time there weren't a large number of female gastroenterologists. That's clearly changed like it has in all of medicine, and we're blessed with lots of female providers in our group and our institution and otherwise. And so I would say that probably about 25% of our women feel very strongly that they want a female provider doing their procedure. But 75% of the people really want the doctor independent of gender or age or whatever it might be. That may be from word of mouth, it may be from reputation, but the key thing is that we certainly try to fulfill people's comfort level. We want people to be as culturally sensitive as we possibly can to make people not have that be a barrier. So we want to also encourage you men to come in, meet the doctors, find out what these procedures are all about this Tuesday, October 5th, 6 to 8 p.m. at the St. Joseph Mercy Canton Health Center. That's at 1600 Canton Center Road in Canton. You meet a famous football player, some incredible doctors,
and can learn about the robotic surgery, including this latest Da Vinci robot that truly is one of the most remarkable developments in medicine, not just for prostate, but for so many parts of the body. And it's fun even just to watch that thing get maneuvered because it's just such an incredible piece of machinery. We have on line 1 a prostate question. Hi, Jacob.
Yes.
What's your question? First of all, how old are you, Jacob?
Pardon?
How old are you?
I'm 61.
Okay, and what's your question?
Okay, my question is, when I use the bathroom, and I go to pee, it takes time before the pee comes out. And then, after I pee, like some of it is left behind and doesn't come out. Could it be that my prostate is acting up or enlarged or something? How can I have that checked?
First of all, I want to commend Jacob for even asking the question.
Oh, I can hardly, your voice is like far, I can hardly hear you.
Jacob, basically, your symptoms sound very typical of an enlarged prostate. Those are very common symptoms. As men get older, you have what's called hesitancy or difficulty in initiating the urinary stream, and then what sounds like post-dribbling, some dribbling at the end. And those are very typical symptoms for someone that has an enlarged prostate. So what I would recommend that you do is that you see your primary care doctor or that you see a urologist to confirm that that's what it is. Certainly, a lot of times patients or friends ask us, what do you think I have? And we can kind of guess what you have, but there's no substitute for getting a physical examination by the physician to confirm that that's what you have.
And was it tough for you, Jacob, to ask the question?
Pardon?
Was it difficult for you to ask that question?
No, not really.
All right. I wish there were more men just like you.
Not really.
Thanks so much, Jacob.
Okay, thank you.
Let's go to Jim. His question, my dad has prostate cancer. Does that put me at a higher risk?
Yes, Jim. We know that if your father was diagnosed with prostate cancer, your odds of developing prostate cancer are twice as high than if you did not have a family history of prostate cancer. So I don't know how old you are, but you should start getting checked with a PSA and digital rectal examination in your 40s. If you don't have a family history, then you can start getting checked in your early 50s.
All right, we have a question from Tony. He doesn't understand the prostate scoring. What do the numbers mean?
Well, prostate scoring, we often use it, I'm not sure. Prostate scoring can refer to either what's called the Gleason scoring system to tell us how aggressive a prostate cancer is, and it's based on a scale of 2 to 10, where 2 is the least aggressive and 10 is the most aggressive. There's also a prostate score for men who have urinary difficulties, where we ask a number of questions related to urination, and then we group your symptoms based on their score. So one can have mild symptoms, moderate symptoms, or severe symptoms of what's called prostatism, and that helps us guide in how aggressive we need to treat that patient. So we need a little bit more information as to exactly what score you're asking about.
And Dr. Shehab talked about colon cancer at times being the silent killer for a large majority of patients. Is it the same with prostate cancer? Can you really get to those critical stages without knowing a thing?
Oh, absolutely. And, you know, prostate cancer is actually the second leading cause of cancer deaths in the United States behind lung cancer. So even though we still screen a lot for it and we catch a lot of early cancers, unfortunately there's a lot of cancers that are beyond our abilities to cure them. Although now we're having better and better success in treating those advanced cancers. But absolutely, I've seen many patients who come in through the emergency room who complaining of a lot of back pain, a lot of blood in the urine, a lot of difficulty with urination, a lot of severe weight loss, and it turns out that they have advanced prostate cancer.
So you talk about prostate cancer being the second leading cancer killer. I always thought colon cancer.
Well, it depends. Overall, in both genders, colon cancer is usually considered the second most common cancer for all Americans. Because prostate is a male issue, it's the second most common in men. I believe that's how it parses out.
I
but
understand.
Clearly, they're clearly in the top three, both of them.
Right. And two cancers that are so treatable and so preventable if they're detected early, but they can't be detected early unless you're willing to talk about it. Here's somebody who at least wanted to email about it. I'm 37 with a minor history of family prostate issues. The grandfather and uncle had problems within the past 10 years. Can anything be detected at 37? Good question.
Yes, that's a good question. Well, basically, prostate problems, unfortunately, can be inherited, both in the form of prostate cancer and enlargement of the prostate. So it sounds like your grandfather and uncle may have had some issues with an enlarged prostate. And basically, that's something, it depends. If you're having problems with urination, then I'd certainly go get that evaluated. Otherwise, I don't think you need to have that evaluated. Otherwise, if you find out that there is a family history of prostate cancer, then starting, certainly you're at an age, you're close to 40, where there's certainly no harm done in going to get checked for prostate cancer.
Let's go to Paul, a 42-year-old white male. He wonders what age he should get his prostate checked and how often afterward.
Right. Well, nowadays, we discuss that generally men who have a family history of prostate cancer or African Americans should start getting checked in their 40s with a PSA and a digital rectal examination. However, on the other hand, it doesn't hurt, even if you do not have a family history of prostate cancer, to get a PSA in your 40s as well as a rectal examination, so that way you at least have a baseline level to which one can compare it to once you become older. Lila, it's not up until recently that we used to consider just a fixed level of PSA of 4 and less being normal and 4 and above being high or abnormal. But we have found out that PSA levels is not like, for example, a sugar level where if it's more than 100, you may have diabetes, or a cholesterol of more than 200 may be dangerous. We have found that everybody's PSA is different. So it's good to have your baseline level, because we have found many prostate cancers where we found that their patient's PSA one year was 1, and next year it jumped to 2 to 2.5. So even though that's still considered a normal PSA level, it's good to have previous levels to compare it to, because we're finding a lot of cancers now if there's a change, what's called in PSA velocity, that's higher than it's supposed to be.
Now, these doctors are amazingly good at multitasking. I know while you're sitting here, you've actually been able to glance at the latest studies about this development of potential breakthrough in a blood test for prostate cancer. Tell us about it.
Yeah, thanks for the information. Basically, there's been a study published from Britain that it's a new prostate cancer blood test that instead of just relying on one protein, which is PSA in the blood, it relies on multiple prostatic proteins that, when put together and analyzed through a computerized system, can much more accurately predict the presence of prostate cancer compared to only PSA alone.
How big might this be?
Well, I think this is very preliminary, but they're saying it has a 90% accuracy in detecting prostate cancer, which would be a tremendous blood test.
Because the industry standard, the PSA, has what percentage?
Well, the sensitivity of PSA is very high for the prostate. It's close to 90%. But the specificity for prostate cancer is about 50%. It's not very specific. It just tells us that there's something going on in the prostate.
So that's why we can get those false positives or get people concerned when it really isn't
exactly,
prostate cancer.
Exactly. So certainly the one disadvantage of the PSA test is that it certainly can make someone quite nervous that there may have something serious going on when in fact they don't. So certainly this blood test may be a step in the right direction.
And the biggest innovation in colon cancer, when we talk about the colon and detecting that cancer, what do you think has been the biggest innovation?
I think it's twofold. I think one is actually the awareness. I think people are aware to have this conversation. That's been the biggest thing in the American Cancer Society, and lots of folks have had impact on that. But I think the other thing is that the test is safer than it's ever been. It's more sensitive than it's ever been. And so the scopes, the biomedical engineers get lots of credits for being able to let us see more than we've ever seen, see it more safely, and do the procedure more safely and comfortably.
They keep making these tools that are so much smaller yet see so much more.
Yeah, well, I think it's just a reflection of how technology is affecting our everyday lives. You enjoy talking about your iPad here.
Can't live without my iPad.
But yeah, the technology that's allowing for robotic surgery is really expanding, changing how we practice medicine. I mean, most of the surgeries that we do nowadays in urology, I finished my training 15 years ago. That's considered old-fashioned urology. Now, most of the surgeries we do are done either robotically or laparoscopically, and also our colleagues at St. Joe's in the who are gynecologists, cardiac surgeons are replacing heart valves, doing bypass procedure with the robot. Dr. Kleer at St. Joe's is also doing the robot for colon surgery. It's also being used for head and neck surgery, so it's really revolutionizing how we practice medicine.
That's fabulous. On this event on Tuesday night, if somebody is willing to come, they're going to be there, what do you hope they go home with? And again, the event is Tuesday night, October 5th. It's at the St. Joseph Mercy Canton Health Center. We hope you'll come. It's a men's health event.
Dr. Shehab can discuss the colon issues, but as far as the prostate, I think I'd like them to come away that you know, prostate cancer, like Dr. Shehab was talking about, colon cancer has a lot of bad rap out there, but in fact, it's not a very difficult condition to diagnose or to treat. And certainly it's scary to think about what can happen to you if you do have prostate cancer and the treatment implications, but we're getting much better and better to certainly preserve the quality of life that's very important so that we can treat you in a very humane way. Certainly quality of life is of utmost importance when we're going to treat you for any type of cancer, especially prostate cancer.
And for the colon?
Well, I think you made the analogy earlier. People know more about their oil level in their car perhaps than this. You need to just have this conversation. Both of these diseases are about having a conversation with your doctor, finding out what the right testing is, and then most of the people, once they've had the conversation, they go on to the test. So the first step is just bringing it up, feeling comfortable bringing it up. So if we can touch 10, 15 people, if not more, who can leave and then go have that conversation with their primary care doc, usually with the urging of their spouse or significant other, then you know what, we'll save lives.
We got a sex question. This is from Bill in Rochester. Is there clinical evidence between sexual frequency and prostate health?
Well, a lot of men would like to have me answer that sexual frequency is good for the prostate.
You'll become a very popular doctor if you answer this correctly.
So I cannot give scientific evidence to prove that. I would tell you it probably can't hurt. I used to have a professor in my training who used to say every Tuesday, Friday, Saturday, but I don't know if there's much validity to that. So,
it's Thursday.
Yeah. So anyway, you know, certainly you have to be aware of sexually transmitted diseases and so forth, and use appropriate precautions. But there's actually, as far as I know, there's no clinical evidence that shows a link between the two.
Mm-hmm. And in terms of colon health, is there any connection?
Not that I'm aware of. No, their studies haven't shown that.
All right, Marilyn from Birmingham asking, how safe is colorectal screening?
Great question. Something that patients ask all the time, and I would encourage patients to ask their doctors not only what do the national statistics show, but what's your own experience?
Right.
What do you find? We find that nationally it's about, we quote to folks, about 1 in 1,000. So about 1 in 1,000 people who have a colonoscopy will have a complication that is enough for them to be concerned about. The complications we think about bleeding after a procedure when something's been removed, and or the complication that doesn't happen anywhere near as frequently as is talked about, but a hole in the bowel called a perforation, where the scope goes through the wall of the bowel. But about 1 in 1,000 is what is quoted nationally. However, if you talk to your doctor, you'll find that many folks have a much less frequent complication rate than that.
If people are going to lunch, give them a quick menu, what you think they should have today to protect their colon, to protect their prostate.
I would tell them have a sandwich with tomatoes in it that doesn't have much fat in it, with a good glass of V8 or tomato juice,
followed by a glass full of Metamucil.
So lots of fruit, lots of vegetables, and for the wife who says, I'm nagging and it's not working, what should she do?
Well, you know, a lot of times wives come in with their husbands to the...
dragging them.
Yeah, and so certainly, and I've seen that plenty of times, so I would just say a lot of times have the wife make the appointment for her husband and just come in together.
And also I'd say have that man drag him to this event and see Freddie Scott, an NFL football player, the picture of masculinity and success in our culture, and realize he got the test, he found this cancer, he got it taken care of. And so just exposing them to the fact that this is what real men do. They get screened for colon cancer, they get screened for prostate cancer, and then they live. That's the big issue.
I want to end with a quick reality check, because we've had fun and we've actually spoken openly, which we want others to do, about colons and prostates. But can you give a little reality check about what it means not to speak about it and not to come in and get tested?
Yeah, well, I've seen time and time again just individuals that perfectly healthy. I've had a lot of patients, for example, who are marathon runners or triathletes, picture of health, who don't think they have anything wrong with them. And then I've seen them, and they have advanced prostate cancer for which cure is not possible. So a lot of times, especially men, think that they're perfectly healthy and they're in good health if they feel fine, but that's not the case. So that's why it's important. Just you take your car for a tune-up, you need to take your body in for a checkup.
Quickly, Dr. Shehab.
And just real briefly, I've had people say, I didn't have time, I had too many deadlines. Deadline's a good word, D-E-A-D. I think, unfortunately, people put things off that they could get done, and they can prevent dying from this disease if they get screened.
Urologist and robotic surgeon, Dr. Kleer, gastroenterologist, Dr. Shehab, both from the St. Joseph Mercy Health System. Thank you so much for all this incredibly valuable information. We hope you'll join us at the Men's Health event. It's this Tuesday night from 6 to 8 p.m., St. Joseph Mercy Canton Health Center. Thanks so much for tuning in.